So we will move on to our second panel. So we will start with Dr. Azma Haryaty Ahmad. She was graduated from Royal College of Surgeons, Ireland, and continue for specialization in emergency medicine at University of Sains, Malaysia. She is a consultant emergency physician with interest in emergency, critical care and critical care ultrasound, a fellow in emergency critical care, and active in research and publication. She also actively involved as training program supervisor and training coordinator. Furthermore, she is our advisor for Malaysia Paramedic Emergency Critical Care Alumni with the title, Weaning in ED, What You Can Help. I present to you Dr. Azma. Please welcome.
Audiovisual problem this morning. All right. Okay. So why do you think this topic is important for a medic? So I will tell at the end of this presentation why it's important for you guys to know how to initiate and how to involve in the weaning of these patients. Right. So before we start knowing about weaning, let us know why is it what is the difference between weaning in ED and also in intensive care. So, and how to make weaning successful in ED. So you need to know the difference between ED and ICU weaning. We need to know the stages of weaning, because we do not know the stages of weaning. You do not know what to do. You do not know what exactly you want to monitor. And then what are the patients that we select to do weaning in ED, and what are the protocols. So this is the differences between weaning in ED versus intensive care or ICU. Right, it need to be a safe and feasible technique and method for you to initiate weaning. You need to provide certain unique logistic and patient features must be met, and you need to have a very strict and proper adherence to the protocol. So because the aim is basically the ED should have a goal of zero re-intubation, and also you need to have the other things that are very important is because the weaning in ED, one of the biggest obstacles is basically to have a very dedicated team, a very dedicated staff who must provide intensive monitoring and recognize and manage extubation failure. Right. So the other issues in weaning in ED is basically because most of the patient who comes to us is the acute patient. So when you have an acute patient, the initiation of treatment is just started. So the progress of patient is just early in the part of management. So if you extubate the patient early, if you start to do the weaning early, the complication of post extubation or post weaning is higher. So the selection of patient must be done very tight, must be follow the strict protocol for you in order for you to be successful in performing weaning. All right, so this is the selection of patient. They got selected of suggested clinical presentation for ED weaning. You either can have patient which categorized as safely attempted for you to perform weaning.
Okay, I think we have some issues here, everyone. Please be patient. So the crew will do the troubleshooting for doctor's mic. So we hope that everything will be fine. So we just wait for a while. Be patient. I'm sorry on behalf of the team. Okay, while we're waiting, if you have any question for Dr. Shaliza, you also can keep on posting the question at the Q&A. So I guess we have a question here. Okay, there is a question. Is Dr. Shaliza around? Is Dr. Shaliza around?
Yes, I'm around.
Okay, doctor, there's a question for you.
All right.
Okay, RSI and emergency critical among the overseas paramedic is quite interesting to know. In Malaysia, is there any planning to develop the CPG or guidelines for AMO in PHC? As far as I know, in UK, they have proper guideline published by JRCALC to refer to whenever they plan to RSI patient at the roadside. Thank you.
Okay. Thank you for the question. Can you hear me?
Yes, doctor, very clear.
All right. So regarding the question that posted to me about this RSI and advanced airway management, I think in overseas there are standard guidelines in terms of delivery of critical care management. Even they are not only concentrate on the RSI, they able to do video laryngoscope, they able to perform surgical cricotherotomy, and they can even do the pre-hospital PSA. And this is quite extensive skill that has been developed under the category of critical care paramedics. I think to answer that, I'm sure it is quite difficult to answer because this should be done and the guidelines should be done by the pre-hospital team rather than our critical care team to just I mean to just produce the guidelines. So I think it is a very good if we can just combine the critical care physician and we can sit down with the physician from the pre-hospital to discuss about what basically the skills that can be done. We can start train the pre-hospital team. We can start to do certain protocol in terms of critical care in future. I think that is my answer for it.
Thank you, Doctor. So I hope Muhammad Hafiz Rosli is the one asking the question, will be satisfied for the answer. Thank you so much, Doctor.
Okay. Welcome.
So we're still waiting for Dr. Azma. Is everything okay? Okay, so here again, please welcome Dr. Azma Haryaty Ahmad.
All right, thank you very much. I'm sorry for the TikTok that happened prior. So let us proceed with our presentation, Weaning in ED, what can you have? As I mentioned, this is a very important topic for the doctors, but maybe for some of the paramedics, you keep asking yourself, why is it important for us to know how to perform weaning in ED? So I will tell at the end of the presentation, throughout the whole presentation, at the end of the presentation, why is it important for you guys to know how to perform weaning and how to know the stages of weaning in ED, right? So before we proceed with that, how to make weaning successful in ED, you need to know the difference between ED ICU and ED weaning and ICU weaning, and then you need to know the proper selection. You know, the early the patient being intubated or the longer the patient on intubation causes more complication post extubation. Right. So this is the difference between weaning in ED versus ICU. That weaning need to be a safe and feasible procedure. We need to provide certain unit logistic, and patient must meet certain of the features that eligible for you to perform weaning. You need to have a strict and proper adherence to the protocol, and the biggest obstacles in ED in performing ED is basically the dedicated staff, especially paramedics, who must provide intensive monitoring and can recognize and manage extubation failure. As we all know, throughout the last 3-4 years that we are doing ADAC critical care, we're able to produce around 100 to 120 of ADAC critical care, and it was spread throughout Malaysia. I don't think it will enough yet at the current moment of time for you to develop a team in your own hospital, but if you do, please proceed. Please make sure you teach your junior for you to perform this. All right. And the other things that you need to know is the disease process, because most of the patients who presented to ED is those patients who present early in the disease process. So you start the initiation early, but the thing that you need to think of, if let's say you have any questions or concern raised about extubation readiness, that patient must be extubated, must perform weaning in ICU instead of in ED. All right, and then the selection of patient, the low risk for extubation must be selected. ED should have a goal for a near zero rate of re-intubation. So this is a few groups of patients that you need to choose for you to perform, either performing or either cautiously performing or not performing weaning at all. So those who are actually under the safely attempted weaning, you can choose patient who actually sustain or have presented with intoxicated or drug overdose with clinical severity, or in those patients who have actually intubated for airway protection for procedural sedation, for example in pediatric or in adult that we went for certain forms of procedure that required procedural sedation in ED, or in those patients with head trauma that required cerebral resuscitation. These types of patients can be performed weaning within 24 hours after intubation if the patient is improved, right? Or in those palliative or terminal extubation patient. Those who actually should not be considered intubated in ED, extubated in ED is basically a patient who is hemodynamically unstable on multiple infusions of inotropic support or on high dose of inotropic support, required the high ventilatory support on those patients who expected prolonged clinical course, for example, in those patients with pneumonia or drowning, and those patients who require repeated invasive procedures or transfer surgical, such as intra-abdominal surgery, shouldn't weaning the patient here in ED, or those with significant neuromuscular disease, for example, Guillain-Barré, myasthenia gravis, shouldn't be extubated here in ED. Or those associated injury to the trauma, injury to the cervical spine, larynx, or lung, shouldn't also be extubated in ED. Right. So before we proceed to the phases of weaning, we need to know the definitions of weaning from mechanical ventilation. This was taken from European Resuscitation Journal in 2007. Weaning covers the entire process of liberating the patient from mechanical support and from the endotracheal tube. So they got two things there. All right. You are liberating the patient from the mechanical support, which is from your ventilator, and from the endotracheal tube. They got two processes that in the weaning. All right. The transition of weaning can be abrupt or can be gradually withdrawal. All right. So it can be abruptly. For example, in those patients who extubated, sudden extubation, they pull up the tube themselves, or it can be gradual. All right. So this is the two process that I just mentioned just now. The weaning is a discontinuation, consists of two components, either the remove the patient from the ventilator or remove the ETT from this patient. So you need to understand the definition of weaning, because some of you think weaning is just remove the ETT from the patient. So it's basically when you want to remove the patient from the ventilator or you want to remove the ETT from the patient is also considered as weaning. This is an example of algorithm of weaning protocol in our hospital. You can see that you can create your own protocol. This is we established this protocol with the help from our intensive care. So we have this for years already. So maybe in certain center you never saw this one, or I think most of the adult critical care saw this when they come to Ipoh prior. So for those nurses or paramedics who never saw one, this is one of the example on the algorithm or on the protocol on how to perform weaning in ED, right? So what are the inclusion criteria for weaning? The patient need to be hemodynamically stable. That's number one. That is the most important thing. Patient shouldn't be on high dose of inotropic support. It shouldn't be on multiple dosage of inotropic support. And the patient, once you intubate, they got no history of uncomplicated intubation. All right. If they got multiple attempts of intubation, the delay, the weaning must be delayed until maybe up the level of ICU admission, right? And then you expect the patient are expected to maintain airway patency post extubation. This can be assessed throughout the process of weaning. Okay, and the resolution of initial indication for intubation, meaning that if the patient comes to you with severe acute respiratory distress, that acute respiratory distress has been resolved, has been taken care of before you start the process of weaning. You need to be able to oxygenate and ventilate on minimal ventilator setting, meaning that FiO2 should be less than 0.6. Your tidal volume as minimal as you can give to deliver to the patient. Your PEEP as minimal as 5 or less. Your respiratory rate is able to maintain the minute ventilations. All right. you need to the patient need to be awake and able to follow commands, meaning that the mental status is adequately enough for you to extubate the patient, and you need to anticipate there is no hospital admission that required another mechanical ventilation. In these types of patient, you can initiate the process of weaning. All right. So for you to initiate the process of weaning, you need to know the stages of weaning. We have 6 stages of weaning. First of all, as I mentioned prior, if the patient presented to you with a certain form of indication for you to intubate the patient, that indication must be taken care of. So you need to give the treatment of acute respiratory failure. You need to treat the initial indication of intubation that you decide prior to the process of intubation. Right, then after the treatment of failure is successful, you go into the second stage where this is the stage of suspicion, where you expect or you suspect the patient can be extubated and can be successful in performing the weaning. Right, the third step is basically to assess the readiness to wean. They got a certain parameters for you to assess to see that patient are ready to perform the next step, which is the spontaneous breathing trial, your SBT. All right, this SBT is performed within 30 to 120 minutes. And within that period, you need to monitor certain parameters on the patient to know either that patient can go to the next step, which is the extubation, which is the removal of endotracheal tube from the patient. And then the next step is the last step is reintubation. This is basically a fail of all the stages of weaning. So if you already went into this reintubation, meaning that the patient throughout the whole 5 stages are not being selected properly, or either are not ready to be weaned yet, or the patient have some form of failure or increase in the parameters that are not supposed to be extubated during the spontaneous breathing trial period. Right, so we go to the step 1 or stage 1, which is the acute respiratory failure. This is the period of care and resolution of the disorder that caused respiratory failure and prompted mechanical ventilation. Meaning that most of the patient who comes to us to ED, before you decide this patient should go for intubation, they must have certain form of reason why this patient required intubation, right? So you need to look either this patient have a respiratory problem or extra respiratory problem. Respiratory problem, for example, a function of the exchanger or your lungs. For example, if those patients have consolidation. In these types of patient, if this patient presented with consolidation of the lung, the weaning need to be delayed, for example, because consolidation will not be resolved within 1 day or 24 hours or 48 hours, right? And then you need to look for the function of the pump, the diaphragm, for example. Is there any diaphragm paralysis? Is there any diaphragm atrophy? If the patient have the diaphragm paralysis, the weaning shouldn't be performed in ED. It need to be delayed until the patient be admitted to the ICU. And you have a look at the function of the airways. For example, the upper airway obstruction, all this must be settled prior to the weaning, meaning that the laryngeal edema has been reduced, the secretion has been cleared. So if all this upper airway obstruction has been managed, so you can then doing and performing the weaning. And then have a look at the extra respiratory problem where the patient have fluid overload or heart failure. In these types of patient, if they're coming to you or presented to you with these two types of problem, you need to tackle, you need to start patient on pharmacological therapy, you need to manage, you have a look at the heart again. Is the heart contraction is improved, the heart ejection fraction is improved, if the heart systolic function is improved, then if it is improved, then you can proceed to the second stage, which is suspicion. All right, what does it mean by suspicion? Suspicion means you suspect the patient will be able to go to the other stages of weaning. All right, we have another stages, right? We already went to stages 1, we treat all the acute respiratory failure. Now at the level of 2, we have another stage of stages 3, stages 4, and stages 5. And the patient shouldn't go into the stages 6, which is re-intubation. All right, then you need to have a reasonable probability of weaning success, meaning that you need to assess the patient and you need to think this patient, if you perform weaning, the successful rate is higher. And then it's important to recognize delay in reaching stage 2. All right, why? Because most of the time the clinician fail to recognize that patient can go the process or the stages of weaning. All right, so they, most of the time we treat the acute respiratory failure, but we never think about performing weaning in patients that actually successfully treated with our treatment, pharmacological treatment, and also intubation, right? So the process of 2 basically not the paramedic problem. Basically, it is the clinician's initiative to suspect this patient. It is good for us to perform weaning. All right. Then we go to the stage 3, which is the to assess the readiness of the patients. Right. It begins when the clinician initiate a process of daily test of readiness to wean. All right. They got a certain things for you to see to determine either that patient is ready to be weaned, and it end when the result of the daily test to cause the reassessment of the probability to a high enough level to justify SPT. Meaning that if that reassessment is good, is achieve the parameters that you are looking for, then you can proceed to the level 4, which is the spontaneous breathing trial. All right, this is the readiness test, meaning that daily after you say the patient is okay to initiate weaning, you need to do a daily screening of the patient PF ratio. Those patients who have more than 200 millimeter mercury of PF ratio is actually included into this readiness test. All right. So, and the patient, if it's on ventilator, the ventilator requirement of PEEP is less than 5 centimeter water, and the FiO2 should be less than 0.5. Right. And the neurological status is good. Patient have intact airway reflexes, meaning that the patient presented, if you test for the cuff reflex, the cuff reflex is present, and they got no indication or no need for continuous vasopressor, or if there is need for continuous vasopressor, the need is very low, meaning that the patient is a low dose of vasopressor, and the patient must not be on continuous sedation, meaning that the sedation has been off few hours early. The patient is able to follow your command. There is no requirement for sedation in these types of patient. So all of these parameters suggest that this patient can go for the next stage, which is spontaneous breathing trial. Right? So on what are the things that paramedics need to have during this readiness test is basically you need to look and reassess the patient GCS over the period or over the times of over the stage of readiness test here. You need to assess the cuff reflex. You know how to do the cuff reflex. You can either slowly pull, not pulling out the whole endotracheal tube. You slowly pull the endotracheal tube. All right, try to juggle, see was the patient produce any cough. All right, this is what we call as cough reflex. And then you need to see either the sedation is off. Most of the time prior to the weaning, we already have this daily sedation off. All right, if you already see the patient breathing is improved, the conscious level is improved, then we do a total off of IV sedation. All right, and then you need to assess, do an assessment on the arterial blood gases and the ventilator setting. Have a look. If the ventilator setting is already a low setting, then this patient is ready to go to the next stage. Right. The next stage, the fourth stage is spontaneous breathing trial. Okay, for those emergency critical care provider that actually attend the causes of ADAC critical care, you know this is the mode that we put for the patient to actually underwent the spontaneous breathing trial. Okay, so for those others who never heard about this, but it's okay, it takes time, slowly over the time this going to be very familiar to you. All right, so what you need to do is you need to put the patient into a few either one of the modes that I mentioned below, either patient on low level CPAP, which is a continuous positive airway pressure, to the pressure of 5 centimeter water, or you can change the mode into a low level pressure support ventilation with the pressure support of 5 to 7 centimeter water, or you can put the patient on SIMV with no pressure support. All right, TPs was performed prior. No, nowadays no more TPs. I think even in ICU is no more use of this adjunct equipment. So if maybe in certain area, for example in district hospital with specialists, you might end up with these TPs. But so far, it is one of the equipment that has been removed from the spontaneous breathing trial. But maybe if you encounter these TPs, you need to know it also can be used for a spontaneous breathing trial. So how long do we perform spontaneous breathing trial? It can take as short as 30 minutes. It can go as long as 120 minutes. All right. If the patient has a prolonged spontaneous breathing trial and the patient cannot be weaned from the ventilator, then you know this patient has fail in spontaneous breathing trial. So after 120 minutes, if the parameters is worsening, then you know this patient are not supposed to go to the next stage or stage 5, right? So what are the risks of failure? So you need to know the predictors for failure in weaning. If the patient comes to you with excessive secretion, please take care of the secretion first before you start weaning, because you know, even you go, if the patient have excessive secretion and you keep continuous with multiple stages of weaning, the chances of patient, even if successful to be extubated, pull out the ETT tube from the patient, but the chances of re-intubation is very, very high. All right. And in the patient who comes to you with arterial CO2 tension, where PaCO2 is more than 45 millimeter mercury, you know this is one of the things that can lead to the failure of weaning. So for example, in those patients with COAD, right, maybe the patient might, that's why patients with AD require a prolonged intubation, because the CO2 takes sometimes for it to reduce. All right, so most of COAD patient has a prolonged intubation, and this weaning process can be initiated in ICU instead of in ED. All right, and if the duration on mechanical ventilation is more 72 hours, all right, if the patient already been in ED for more than 72 hours and been extubated in more than 72 hours in ED, please avoid doing weaning in ED. You can do and perform weaning later in ICU. Or if the patient have upper airway obstruction, please avoid this, or a prior failed weaning attempt, meaning that we already do SBT, the parameters is worsening, meaning that the patient failed SBT, please do not maybe need to start thinking either, oh, this patient already went ×1 failed SBT. So the chances of developing a second failure of weaning is very high. So if you have these types of patient, discuss again, maybe can be delayed until the patient being admitted to the ICU. All right. So this is the process again, the all 6 stages of weaning, as I mentioned just now, from the ED visit until the time of ICU admission. You know, while you are doing the spontaneous breathing trial, 20% of patient will fail this phase, right? So in other words, out of 10 patient that you performing SBT, 2 out of them will fail SBT. All right, 2 out of them will fail SBT. Out of 5 patients that went for SBT, 1 of them will fail SBT. So, all right, so it's actually quite high. So that's the reason why the selection of patient, the stages must be followed very accurately, right? So how do we define weaning if you base on the spontaneous breathing trial? Again, We have a simple weaning if the patient are able to be extubated after the first spontaneous breathing trial. All right. If the patient failed the first spontaneous breathing trial, now it's already considered as difficult weaning. When the patient goes into second spontaneous breathing trial, fail the second, goes to the third spontaneous breathing trial, that is considered as difficult weaning. After the third attempt of spontaneous breathing trial, is already considered as prolonged weaning. We don't want the difficult weaning and prolonged weaning to be done in ED. What we want is the first SBT. First SBT need to be successful and that patient can be extubated in ED after the first spontaneous breathing trial. We want that simple weaning to be performed in ED. All right. So what do you want to observe during spontaneous breathing trial? As I mentioned, that spontaneous breathing trial need to be done within 30 to 120 minutes. During that 30 to 120 minutes, you need to look at these parameters. This is your job, all right? Because sometimes doctor initiate the weaning, they run away, all right? So we need to have a team to monitor these types of parameters during spontaneous breathing trial because it takes about 30 to 120 minutes. So if these parameters is worsening within that period of 30 to 120 minutes, you know your spontaneous breathing trial is failed, right? So have a look at the respiratory rate. If respiratory rate worsening from the current respiratory rate to more than 35 per minute, you know something is wrong with the patient. If the SpO2 is declining from a normal SpO2 of more than 91%, now suddenly less than 90%, something wrong with the patient. If they got sustained increase in 20% of heart rate from the initial heart rate prior to the spontaneous breathing trial, something wrong with the patient. Patient is under stress already. If the heart rate is increasing more than 140 per minute, or the systolic blood pressure worsening from initial blood pressure to more than 180 millimeter mercury in systolic or diastolic more than 90, please take an extra careful, be more extra careful. Or if the patient, this is one of the subtle signs that most of the time we miss, if the patients come to you with diaphoresis, all right? If the patient start to sweat, you know something is wrong. Patient required a higher energy, actually asking for help in other form of other parameters. So please, if you have a diaphoretic patient, if the patient start to sweat, you know the patient is already in stress. Okay, if you have these 6 parameters during the spontaneous breathing trial within the period of 30 to 120 minutes, stop your spontaneous breathing trial. You already failed the spontaneous breathing trial. For example, okay, if you already start within that 30 minutes, the parameters already occurred within that 30 minutes. All right, it's the initial stage already. Within the first early 30 minutes, the trial, the patient's parameters are worsening. Stop your spontaneous breathing trial. All right, so that spontaneous breathing trial cannot be performed for the next 60 minutes or 120 minutes. It must be stopped once the parameters is worsening, right? But if the parameters is maintaining throughout your 30 to 120 minutes of performing SBT, you can go to the next stage, which is extubation, right? So this extubation meaning you remove your endotracheal tube from the patient, okay? Right, so even though you able to remove the endotracheal tube, they got the chances of re-intubation as early as 24 hours to 72 hours post removal of endotracheal tube. It can occur in 5 to 30% of patients, all right? So most of the time we extubate patient here in ED, but the re-intubation occur in ICU. So most of the time we do not know that we actually caused this failure of weaning, all right? Because we never call ICU, we never follow up the patient, so we do not know that patient already goes into the 6th stage of failed weaning, which is your extubation, which is your re-intubation. So please follow up your patient if you're already doing weaning in ED to know the progress of patient in ICU if the patient already been admitted, right? So what are the failure? What is defined as a failure of weaning from the mechanical ventilation, right? It's failure of spontaneous breathing trial, as I mentioned prior, need for reintubation within 48 hours following extubation, all right? So after 48 hours, patient being reintubated, that also considered as failed weaning, all right? Even though in ED for the last 48 hours was okay, go to ICU 48 hours, within that 48 hours, another 2 minutes of 48 hours, patient need to be reintubated, is also considered as failed weaning, all right? The other thing is death, all right? Death within 48 hours following extubation, that also considered as failed weaning, okay? It, of course, it can be because of other process, but if the patient died because of other process, but if there is a history of extubation within that 48 hours following death, then you know that also part of criteria or definition as failure in weaning. Right. This is the most important things for you paramedics, yeah. All right, because whatever that we do, it always associated with complication. All right, these are the complications of post-weaning. Most of the time, patient will come to you with laryngeal edema. All right, weaning-induced cardiac dysfunction, thromboembolic complication, weaning-induced pulmonary edema. All right, weaning-induced pulmonary edema, post-extubation dysphagia and delirium. All right, so the sometimes we miss all of this because we one of the reason because we do not know all about this complication of post weaning. Okay, so when our brain didn't know, we are not looking for it. All right, so these are the 6 main thing complication that you need to be aware of, that you need to tackle off during the whole process after the extubation, after the removal of endotracheal tube from the patient. Okay, so we go one by one. How to do the monitoring for this post complication, for post extubation complications. All right, for a weaning induced cardiac dysfunction, in all patients actually went extubation, you need to perform a 12-lead ECG with a continuous cardiac monitoring, and some of you can also perform cardiac ultrasound to have a look at the patient's systolic function, right? And in the event of thromboembolic complications, have a look at the patient distal lower limb pulses, checking the lower limb swelling, have a look at the pain over the lower limb, have a look at the respiratory status. If the patients have DVT, now goes to the pulmonary embolism, look at the respiratory status. Was the patient getting more breathless? All right, have a look at the oxygen pulse oximetry, either is worsening or also you can monitor the cardiac monitor in certain patient of thromboembolic complication. If they develop pulmonary embolism, most of the patient will come to you with sinus tachycardia. All right. Other things is delirium. Okay, delirium can be divided into 2 types of delirium, which is hypo types of delirium and hyper. All right. So in those patients with hypo types of delirium, what does it mean is basically patient tend to go to sleep all the time, is very difficult to be aroused. Okay, so these types of patient we like, isn't it? Because it seems like the patient are sleeping all the time. Okay, it's not aroused. Okay, but this is one of the types of delirium that you need to care post extubation. The other types of delirium is hyper types of delirium, in where the patient is agitated, is very restless. Okay, this is basically get our attention more because patient try to jump over the bed, patient is shouting. So you know this is another. Both are actually very important for you, for us to identify. All right, and the most important things, certain patient, for example, in those patients with hyper types of delirium, you can start patient on sedations. All right, and you need to have a assessment on the mental status over the time. All right. And what about the post-extubation dysphagia? Right, this may be not so obvious in our setting, unless the patient stays longer post-extubation. All right, so you have a look at the patient, because most of the patient post-extubation we start to initiate feeding, right? So ask them to have an oral feeding. Can start off with clear fluid and then soft diet, see how it goes with this change of dietary modifications. Okay, and then sometimes they say the postural changes, maneuvers also very helpful in these types of patient. Meaning that if the patients are lying flat on the bed, you can put the patient prop up 45 degree or 60 degree to improve the post extubation dysphagia. Right. This is another things that we also frequently miss in post-weaning patient. Patient might presented with pulmonary edema post-extubation. The reason why, because you are giving patient some form of sedation prior, patient in a relaxed condition, you are giving some form of pressure support using your ventilators, suddenly you take it everything out from the patient. So patient need to breathe on their own. Patient need to use the highest catecholamines to maintain the breathing, to maintain the wakefulness. So this increase in catecholamine will uh, create where we can cause pulmonary edema. All right, so if the patient presented to you with pulmonary edema, then you can actually do monitoring by looking, of course, clinical number one. Number one is always a clinical, but you can use your ultrasounds for you to look at the heart, for you to assess the B lines in the lungs. All right, so have a look at the B lines. Is it increased, or was there any changes of B line pre extubation and after extubation? Right. Certain patient will develop laryngeal edema. They will come to you with stridor. So you can give patient steroid. You can give nebulized epinephrine to these types of patients. All right. Even though the effect is actually takes some time. For example, if you're giving steroid, it will take about 6 to 8 hours, but still it can be initiated early in ED. Right. So this is a checklist. Have a look at the checklist again and again and again. Monitor every boxes, tick every boxes. Is everything is okay? Meaning that stop sedation. Was patient already on sedation? Was patient have a control when have switch from the SIMV to just spontaneous modes of ventilation, or if the patient successfully went spontaneous breathing trial, if the fluid balance is negative. You don't want the patient to be positive 1,000 or 2,000 fluid. So if you need to make sure the fluid balance, you need to make sure the urine output of the patient is adequately or being put in negative balance. Yeah. All right. Have a look at the normal mental status, the respiratory secretion, the adequacy of cough. If everything okay, then yes, you can intubate. Right. So what you need to do, you need to monitor regular neurological and mental status, monitor for the successful and failure of spontaneous breathing trial as based from the parameters that I just discussed prior, and then have a look at the regular, need to perform a regular suctioning on this patient to make sure you don't have excessive secretions, performing maneuver checking for the cough reflex. You pull up the ETT slowly up and down and see was the patient able to cough, and check for the leak test. How do you want to check for the leak test? It's easy. It's easy if you have a very good ventilator. I'm so sorry. If you have a very good ventilator, what you need to do is basically open the ventilator, have a look at the percentage of leaking. All right, have a look at the percentage of leaking. You get your 10 cc syringe, all right, deflate the cuff, all right, deflate the cuff. You can see if the leaking is increasing, that is considered normal because your cuff is already deflated, all right. If the increase percentage is not so many, all right, you need to expect they got some form of swelling or edema that's surrounding the endotracheal tube, meaning that no, the leaking is less because it's actually obstructed by the edema. So if you have this reduced leaking, or the number of percentage of your leaking is not improved, meaning that the patient have edema, the cuff leak test is unsuccessful. Do not proceed with extubation or removal of endotracheal tube from the patient. Right. So I hope by this point of time, you need to know why this topic is important for paramedic. Number one, we need you. We need you to form a dynamic team. It cannot be just doctor to performing the ED, the weaning, but we don't have people to monitor the patient. So we need you. We need to work as a one team. We need to be a robust and very good dynamic team. All right. So the other things to why is it important in performing in telling you about weaning in ED is basically for the purposes of monitor. So every phases, we have phase 1, phase 2, phase 3, phase 4 and phase 5. All right. So every phases of monitoring is important to include you as part of the team. All right. And post-weaning complication. Of course, sometimes detections of post-weaning complication is not by the doctors, it's by the paramedics. So this is very important, where you guys need to come and help us in order to identify and to manage these post-weaning complications, right? And then the continuation of care to the patient, meaning that one shift already do this, that paramedic that work in that shift need to pass over to the paramedics in another shift. So the continuation of care from the start of initiation of weaning phase 1 until to the level of phase 5 before you fail and goes into the level of phase 6. So this continuation of care to the patient is very, very important, and this is the reason why this topic is very important for you guys to know, at least to know, or at least now have a little bit of idea on how to perform ED in weaning. So with that, I thank you. Do you have question? Okay.
Thank you, Dr. Azma, for the amazing sharing. So, Doctor, we have 2 questions for you.
Okay, question number 1, is it? Can we describe weaning same as reversal
Yes.
phase for extubation in NS setting? Yes, it is. It is the similar things, all right? Reversal phase for extubation in NS setting, weaning is the same thing, all right? So, the phases is still similar. Number 1, number 2, number 3, number 4, number 5, number 6. It goes the same phases, right? And then the question 2, just curious, when we talk about ED weaning, how long are we expecting the patient to be in ED? All right, my ED can have patient up to 96 hours, 5 days. All right. So I am lucky. I am lucky because I have this patient stays longer with me. Good for the patient, good for me as well because I can learn. So of course, if you have a patient who required ICU admission, do not put the patient in ED for just purpose of doing weaning, okay, or trial of doing or performing weaning in ED. If the patient can go up to the ICU as soon as possible, send the patient up to the ICU, all right, and do perform weaning in ICU. But I already mentioned to you, weaning does not mean only extubation of endotracheal tube or removal of ventilator from the patients. The weaning start off from the phase 1, isn't it? Phase 1 is when you treat acute respiratory failure. So you already start weaning in the phase 1. All right, phase 1 is weaning already. Okay, treat acute respiratory failure. This is what we do, isn't it? Most of ED, we treat patient acute respiratory failure. All right, and then number 2 is to suspect either this patient is able to perform weaning or not. All right, if the patient able to be suspect, you already go into stage 2 already. Okay, or maybe you have longer time. Or no, okay, already suspect can go for weaning. Okay, maybe I can look for the readiness for wean. Okay, look at the parameters. Try to reduce the PEEP. Try to reduce. Have a look at the ABG to look at the PF ratio. Either this patient PF ratio is already goes to more than 200. Have a look at the neurological status. Have a look at the mental status. Assess the readiness of weaning. All right. Then, if able to that, go to SPT. Maybe we can able to go up to the phase 3 or stage 3. It's okay. We already go into the stages of weaning. All right. But maybe we have out of thousands of patients, we can able go to the phase 5, maybe 1 or 2 within a year. Good, you're able to go to the stage 5. But bear in mind, weaning does not meaning that you should go at stage 5 in ED. All right, but the initiation of weaning must be performed, must be initiated in ED. Start phase 1, start phase 2. You are lucky, you can go to phase 3. If you're more lucky, then you can go to phase 4. If you're lucky, you can remove the endotracheal tube from the patient. Right? So my How long we are expecting the patient to be in ED? Depend on your center. All right, if the center 6 hours can go up, intubated patient 6 hours can go up to ED, you can maybe initiate only phase 1 and phase 2. All right, if the patient stay longer, like my center up to 5 days, I can go up to stage 5. I can even monitor up to the stage 6. All right, reintubation. Okay. Right, I got another one question. What is the target level should he or she must have in order to apply it on critical care settings in ED? Does it future we have credentialing or privilege? Yes, I'm agreed to that. All right. So again, you don't have to have credential on this. Monitor what? You guys already been credentialized to monitor the patient, right? I don't ask you to touch the ventilator to adjust the patient on from the whatever ventilator setting that been put by the doctors to the pressure support ventilation or SIMV with no pressure support. All right, that order, that decision must be done by the doctor. I'm so sorry to say, at the current point of time, the decision to do weaning is still under the medical officer, the specialist. So, but can you change? Of course you can change, provided the MO or the specialist is there. Specialist said to you, instruct you, okay, now can you change the ventilator setting to SIMV with no pressure support? Change it. Yes, you can do that. Meaning that the directive must come from the medical officer or from the physician. But monitoring part, I don't have to actually give an order. This is your job. All right. So what are the level? It can be done by all paramedics. You don't have to have credential for this. But certain things on how to take care of the ventilator, of course, you need to have certain form of credentialing and privileging. Even my ADAC critical care also have some form of difficulty in doing this, all right? But it's okay. It's not about it's not about on how to manage the ventilator. It's about how important we work as a team in order to make sure our weaning process is successful. I hope it's answered your question. Right? Thank you very much. Have a good, nice presentation session after this.